All right, thank you for joining the Ohio ACEP Zoom. I would like to thank the chair of our candidate Young Physician Committee, Dr. Bob Jones, as well as our Ohio ACEP resident board member, Dr. June Umanaga, for inviting Dr. Michael Weinstock, author of the Bouncebacks series. Dr. Jones, I'm going to go ahead and hand it over to you for the introduction of our speaker.
Okay. All right. So we're excited to have Dr. Weinstock. Dr. Weinstock is an emergency medicine physician as well as the director of research, stroke medical director, and medical director of graduate medical education at the Adena Medical Center. He's also an adjunct professor of emergency medicine at The Ohio State University, as well as being the risk management section editor for MRAP and the executive editor for the new podcast UMAX, which is part of the MRAP family of products, and has been the principal investigator for the original research published in JAMA and Annals of Emergency Medicine, and is the risk management section editor for Corpendium. He's the author of the Bouncebacks series of books, and Dr. Weinstock has practiced emergency medicine both nationally and internationally, including volunteer work in Papua New Guinea, Nepal, and West Indies. His research interests include ED evaluation and management of chest pain, patient safety, emergency medicine, medical education, and of course, bouncebacks. So now we're excited and we're going to turn this presentation over to Dr. Weinstock. So go ahead.
All right, Rob. Well, thank you so much. And also, Holly and Stephanie, thank you so much for having me. Folks who have joined, I hope to be true to the time that you have given me because this is all about not only patient safety, of course, but also about our own safety and our maybe even career longevity, right? So I intend to give you some pretty practical things that you can do on your next shift. As well, I also want to focus in on some specific cases, and hopefully this will be just a little bit interactive because the case that I'm going to show you are actual cases and actual cases, unfortunately, that ended up in bounce backs. So I'm going to start sharing my screen. I have nothing to disclose. No, I don't get a kickback every time someone sends a patient home and they bounce back. So that is, just something obviously out there. So at any rate, I want to start off with a scary number, and this number is 17. And if you extrapolate out from a study that was done by David Sklar, published in Annals of Emergency Medicine, 17 is the number of patients that each of us will send home during the course of our careers that will bounce back from a potentially avoidable death within 7 days. 17. When you think to yourself, wow, in the course of a career where I see between 150 and 200,000 patients, that's pretty good. You're like 99.9% correct. However, if you think to yourself, wow, I've lost 17 medical malpractice lawsuits when I retire, maybe you wouldn't think it quite the same way. So what I'm going to do is go into that study just a little bit more so you know exactly what I'm talking about. And then we're actually going to come up with a specific approach to spotting patients who might bounce back and then what to do about it before we let that patient go home. If folks heard the MRAP risk management topic that I did the first Monday, I do those every first Monday of the month. That was with Amal Mattu back in August. One of the things that he said, and that's sort of the key to all of this, right, is to just before you send a patient home, just imagine, right, well, what happens if they do bounce back horizontal and room temperature in 48 to 72 hours? What did I miss? What could I have caught? What should I have done? But it's a balance, right? Because it's a balance between doing too much testing, which potentially could cause harm, and between not doing enough testing and obviously missing something. And our national organization, ACEP, in the 2018 chest pain guidelines, actually specifically said we do have now a 1 or 2% acceptable miss rate for missed non-ST elevation chest pain patients. And they specifically say in the document that trying to get below that 1 or 2% threshold will result in patient harm from false positive tests, as well as all the other things that we know when we do over testing. So anyways, that balance is what we're going to look at a little bit more today. Okay, so the study that we talk about is SCLAR, and there's some other studies, and interestingly and very excitedly, I'm actually duplicating that study right now, but with a little bit of a twist to it. And we have all the data, IRB approval, and the statistician is going through that data to get me stuff compiled. So this is pretty exciting. And I mean, hopefully you'll hear more about that in the next, maybe, I don't know how long it'll take us to get our stuff written up and submitted, hopefully accepted in the next year or so. But at any rate, the patients that he looked at were almost 400,000 patients at the University of New Mexico Health Sciences Center. And the reason that they thought this was unique is because of the tertiary care center. They thought that all the patients that did bounce back would come to that location. So they found four themes of the patients who bounced back and died a potentially avoidable death, which were 35 out of 387,000 patients. In other words, about 1 in 11,000 patients. And again, extrapolating that out to the 17 patients, depends how long you work, right? How fast you are. But at any rate, they found atypical presentation of an unusual problem, hard to sort of help with that. Chronic disease with decompensation. I mean, of course, I say sometimes age is a risk factor for death. Patients with mental disease, psychiatric illness, substance, probably decreased ability to obtain adequate data, usually history, but maybe history and physical, right? And then abnormal vital signs. But here was the absolutely astounding thing from the study, and you probably heard attendings quote this and talk about this, or maybe that I've quoted Sklar, I'll give him all the credit, is that a full 71% of those possible error cases, 71% had unexplained tachycardia on discharge. Astounding. So when we get to the very end of this, and I talk about how to spot the well-appearing patient who will or may be soon to be dead, and the approach, one of the things about how to spot that patient will be patients who have abnormal vital signs, specifically that unexplained tachycardia. And I just want to also say, as a sort of preface to all this, I would love if folks chime in. You can certainly unmute, ask a question. You can put stuff up in the chat, all good. I'm happy to have all of this be pretty interactive if folks are able to do that. Can you guys can see, Holly, the whole screen, right? You
Yes.
don't see like my chat thing pulled up. Okay, perfect. I just want to make sure any part of these gorgeous slides is not able to be seen by everybody. But I do have the chat pulled up if folks want to look at it. So before we talk about a few of the bounce back cases, and I want to be very, very strong on this, just because a patient bounces back does not mean in any way, shape, or form that a medical error was committed, and does not mean in any way, shape, or form that medical malpractice was committed. Because we do want some of our patients to bounce back. Now, I'm going to give you an example, a couple examples of that. And I will also say, I have a lot of prefaces, I know, but all the things that I'm telling you are based on either literature, just some of the data we'll put out in the beginning, or, rarely less of that, but based on my own personal experience. So if you ever want to ask for the original reference for the statement that I'm making, please ask me about that. I will send you the article that supports it. So it's all like a referenced article with little footnotes, but I'll try not to make it quite as boring as reading a referenced article. So at any rate, the two examples that I want to tell you about, the first one is, and we see a million patients, right, with ureterolithiasis, ureteral colic, and, we send those patients home almost all the time. Doesn't matter, hydronephrosis, like, if it's intractable vomiting, if it's intractable pain, and there's some other things too, of course, unilateral kidney maybe. But anyways, short version is we send them all home. In my experience, about 1 in 20 come back because their pain's not able to be controlled with whatever we give them for, analgesia at home. That's not an error. Of course it's not. The expectation to the patient that whatever the exact number is, 1 in 15, 1 in 20, whatever, that they might need to come back is great. That's important for us to do because we want to make sure that first they will come back. We don't want to miss that infected stone that wasn't present initially, as well as the fact that when patients do come back, they don't want to feel like, oh, I never should have been sent home. And again, that's part of that shared decision making, which I sort of feel like sometimes transitions into CYA. The SDM goes to CYA. I'm in the process of an article on that too, but we'll see when that comes out. The other example is a patient with appendicitis. And there was a study by Bickel in the Journal of American College of Surgeons who looked at the onset of symptoms until rupture. And they found less than 2% rupture at 36 hours. Well, that's pretty good, right? But if you send home a patient at 24 hours and you think it's really, really unlikely, maybe you don't do imaging because you think it's so unlikely, well, the patient's expectation that if their symptoms progress, change, worsen, they need to come back, that might be a totally safe and really excellence in medicine type of thing to do. However, 2% is not 0%, right? So anyways, just because a patient bounced back doesn't mean it was an error or medical malpractice. So what is malpractice? I'm going to give the formal definition first. And the formal definition is sort of easy, probably something you've heard in the past. The physician has the duty and there was harm. Usually very easy to prove. The physician has the duty. In other words, we're wearing a white coat, the patient's shivering in a thin hospital gown, and there was harm, right? The patient, like I said before, is cold and horizontal, right? Room temperature and horizontal. The two things where we argue and true malpractice, to use the words of Greg Henry, true malpractice is settled. If something actually goes to trial, that means that there is some type of argument on either side in general. Physician has breached the duty. That's the standard of care. That's to do what a reasonable physician would do in a like or similar circumstance, like or similar training, as we've all heard. And then number 4 is causation, which is sometimes called proximate cause, and is basically that what we did or didn't do actually resulted in the harm, right? So you can look at that in different ways. Failure to make a diagnosis is what we didn't do, maybe some type of test, or maybe what we did, giving a inappropriate medication or the wrong dose of it. There was a medical legal case I had where they doubled the dose of TPA and they gave the MI dose of TPA and not the stroke dose of it, and the patient had a brain bleed. It's sort of hard to defend, right? So anyway, that's the standard of care and that's the causation part. I sort of feel like it's easier to just think of it in a different way. And this is the Weinstock definition of malpractice. You will not read of it in any medical journals, I assure you. And it's two things, and it's super easy: poor data gathering and poor medical decision making. And in the end, I will tell you, and I've done almost 150 medical legal cases in my sort of medical legal expert type of career, and I will tell you, most of the time, the data will say 87 to 92%, but say 9 out of 10 times, you're either going to make the diagnosis or drastically narrow down the diagnosis just with your history alone. Now, that's the data gathering, and I've said this quote, broken record alert, there'll be a lot of broken record alerts here, that a good history is free, but a poor history can be very expensive. And the history that you get when you're just sitting in the room and talking to the patient, that's the history that's free. So why wouldn't you take advantage of that? And I'll give an example of that also. So when it comes to chest pain, that's my main research interest, but based on a study by Farinoff, about 1 in 10, might be 1 in 20, but say 1 in 10 of all of our chest pain patients in the ED, about 7% of our patients are chest pain. We'll see maybe 10,000 in our career, just to keep it a round number. About 10% of our chest pain patients will have ACS. And we think of ACS PE dissection as our big 3 of chest pain, right? About 1 in 100 will have a PE. And based on a study by Alcher, about 1 in 1,000 will have a dissection. So when you think about it, you're 99.9% right for aortic dissection before you even do any testing at all. But again, that's not quite good enough. Now, when you think about those 3 things, ACS, PE, and dissection, the testing is very different for all of them. Because for ACS, the most basic of tests we would do, EKG troponin plus minus chest x-ray, does not rule out PE dissection. A dimer for, say, a low or moderate risk patient does not rule out a patient with a dissection. We could talk about some of that data and some of the stuff later, but just for the sake of the argument. And then for dissection, obviously it's a CTA that we're doing for at least, would say, moderate to higher risk patient anyway. So the testing is different for all of them, but it is absolutely astounding to me that when I look at histories, that so frequently there was not even one single question asked as to the consideration of PE or dissection. And in the end, what was that doctor doing? They were just hoping to get lucky. And in the end, we probably will get lucky because 99% of the time we're lucky that it's not a PE, and 99.9% of the time it's lucky it's not a dissection. Okay. So poor data gathering, poor medical decision making. And what I would recommend in your medical decision making is to do this thing called a hard stop. We'll talk about it in just a few minutes, but our chart is a story. It's a story that's told from the beginning to the end, and it should make sense. It should be a logical story. And when someone finishes hearing or reading that story, they should feel like they were in the room, that they agree with the approach and the plan and the management of that patient that was done. Okay, in just a sec, we're going to get to a little more interactive part here, but I wanted to sort of preface it with those things. I'm going to give you a couple more stats here, just real briefly. We'll go through these things super fast. Most of us will be named at some point of our career, about 3/4 by the age of 75. Most suits are dropped or withdrawn. That's good, about 2/3. Only a small percentage go to trial, about 7%. I've found in my medical legal career, as far as again, an expert, that it's even less than that, but that's the data that's quoted. If you do go to trial, the verdict is usually for the defense, but again, quoting Greg Henry, at a medical malpractice trial, there are two losers. There's one loser and a bigger loser. So you certainly don't want to go all the way through to trial if you have a choice, right? The best way is to avoid this in the first place. Okay, the most common reason is failure to diagnose, but the best way is to avoid a lawsuit in the first place. Okay, so I've wondered about this question through the course of my career. Can the act of documentation, something that usually most of us don't really love, like you didn't say at your medical school interview, you wanted to be a doctor because you loved documenting and throughput, although that was probably the most honest of the answers if we'd have known it at the time, right? But can the act of documentation actually make patients safer? So we'll talk about that in a little bit. I also want to just very briefly talk about the balance in medicine. And it's not only balance between what we talked about before, the risk of overtesting and the risk of missing a diagnosis, but between what I call the three S's, which are safety, speed, and satisfaction. So this balance is super important. And sometimes these things, it's not a zero-sum game. Sometimes they feed back on each other. So speed can help with safety. In other words, patients aren't waiting as long in the waiting room. Speed can help with satisfaction. In other words, if I was a patient, I'd rather wait for half an hour instead of 3 hours in the waiting room, right? So the three S's, safety, speed, and satisfaction, super important to go through all those things. So we're not always just looking for the needle in the haystack, but in the end, what separates us as physicians or PAs or NPs, right? What separates us from just getting lucky with aortic dissection, and it's that ability to catch that last case, which you could call it the needle in the haystack or something else. So I'm going to give you one final slide, and then we're going to go into a couple real cases, and we're going to talk about those things, and hopefully you guys will humor me and be a little bit interactive with this. I know it's sort of hard on Zoom, but I'd love to have you guys join in on things just a little bit. Super safe space here. Okay, so when I think about a patient's presentation, I think about the most obvious things, usually number one and number two, the patient is asking a question. So when a patient comes in at 5 o'clock in the morning with chest pain, they're not asking us, do I have Boerhaave syndrome? Do I have acute viral bronchitis, right? There's a concern, of course, like my neighbor, right? They're concerned about a heart attack. I mean, of course, right? But the question that's asked to us as EPs is not simply, am I having a heart attack from the patient? The patient's presentation is asking us a question. And at its most basic, a chest pain patient is asking us, could this be ACS, PE, or dissection? And that's just one example. I keep using the chest pain because we think about it so frequently. When a patient leaves to go home, we'll talk about this at the end. We're going to come back to this consideration. It's really, really important to think about what Steve Clucciello and I think some others have called the last chance to get it right, which is the patient's understanding of a concept called diagnostic uncertainty. Diagnostic uncertainty is fine. I'm sending home tons of chest pain patients, as I'm sure all of us are. When I did one of, well, anyways, I won't talk about that study, but in 2015, I published a study in JAMA IM, and 50% of patients were actually being admitted, 50% of chest pain patients. And now we're down to, I don't know, 10, 20%, whatever it might happen to be. I'm happy to talk about heart score and all kinds of other kind of stuff at another time. But at any rate, it's okay to send a patient home with some diagnostic uncertainty, but the patient needs to understand that if things do get worse, they need to come back. Okay. Well, that being said, I have two real cases here for you, and I want to talk about those. And I'm going to start with what we always do is a patient story. So for anybody on the line here who is interested in joining in, I would love if you guys would do this. It will, I promise you, make this much more interesting. And you can sort of unmute. You can put your video on if you want. If you don't want to do it, I get it. I always sort of hated that thing when I was a resident when people called on me. So I totally get it. All good. But again, it would make it sort of more interesting. So it is our opportunity to be an armchair quarterback, sort of criticize someone who's not there to defend themselves. So anyways, we can be a little snarky about it. What's more fun than that, right? At any rate, this is the first case I'm going to talk to you about. It's a 5-year-old boy with vomiting. Now, this is a true story. I'm going to tell you the patient's story, and I'm going to tell you our story in the words of and the documentation of the emergency physician. This is Jordan. He's 5 years old. He's healthy. He's recently had an appendectomy. He is living with his mother, who's an attorney. She's a public defender in Georgia, and she has a busy case. So she asks her mother, who you see pictured here. This is just a mock-up, right? But at any rate, she asked her mother to come down and watch Jordan because she's in the middle of this busy case. And so she fixes Jordan some eggs and cheese and orange juice for breakfast. And soon after that, Jordan starts vomiting. So we're going to come back to this whole chart in just a second here. But I'm just going to give you the nurse's note, vomiting of food, 8:45 a.m. after eating eggs and cheese. And you can see the patient presented at 11:10 a.m. Grandmother is concerned for food poisoning and pretty much negative review systems elsewhere. The physician documents, and I'll just read this whole thing. I'm not going to read the whole chart to you, I promise. Jordan, previously good health, 3 episodes of non-bloody, non-bilious emesis over 2 hours after eating the eggs, cheese, toast, orange juice. Denies all these other things, abdominal pain, diarrhea, URI symptoms. His vomit is not associated with coughing, so it's not post-tussive emesis. Not sure that's super helpful, but maybe a little bit. Urinated once a day, no PO intake, no prescriptions given. And all this is not really incredibly surprising, right? Jordan came in at 10 after 11 in the morning, and his symptoms started, 2.5 hours prior to that. So the fact that he hasn't peed since then, he peed when he woke up, I mean, that's probably sort of normal for anybody, right? Okay. His past history, I told you about, he had an appendectomy in the past. He lives with his mother, and then the grandmother's there. Here's his vital signs, his heart rate. You can say maybe a little bit elevated, but for a 5-year-old, not as elevated as mine would be if it was 135 right now. Hopefully it's not. He's alert and well developed. His abdominal exam, and you remember that he said he has no abdominal pain, denies abdominal pain. But on the exam, they do say that he has mild diffuse discomfort to palpation. So we'll talk just a little bit about, again, history is free and report history can be expensive. Same with the physical exam. I get it. And I put that on my charts too. Head normocephalic, atraumatic. I'm not criticizing anybody here. But, just sort of saying sometimes when you think about a patient who is 2 years old and you put in maybe another thing we put on all of our charts, alert and oriented times 3. I mean, it's okay. You probably didn't ask them person, place, and time. I sort of prefer to have something like the 2-year-old is running down the hall screaming and laughing while the parent is chasing behind. But, I get it. That's all good. I would say for the abdominal exam, and this isn't bad, but, with a cardiac exam or abdominal or, GU, all those sort of things, maybe it's good to have something even a little bit more extensive. Okay. So the kid is diagnosed, Jordan is diagnosed with gastroenteritis, sent home with a prescription for Phenergan. Okay. So that is the end of the presentation here on this. I'm going to put his whole chart up here. It's exactly what you saw. It maybe is a little bit more extensive here, but why don't we do this? Why don't we talk about first the data gathering, as I'm perseverating on, and we can talk about data gathering as far as the history exam. And I'm not saying any testing should have been done, but if you think it should have, right? And then we can talk about the diagnosis and disposition. In the middle of this, we're going to take sort of a fun little break. But at any rate, anybody want to unmute or put their camera on and see what your thoughts are? For example, if you had a medical student or a junior resident present this case to you, maybe you're cool with it. I'm not saying this was like a horrible evaluation of management, but if anyone has any thoughts on maybe what they might have done differently or maybe stuff that was well done.
Hey there, Dr. Weinstein. My name's Kyle Deming. I'm a resident PGY1 at OSU,
Nice. Hi,
Ohio
Kyle.
State University. Hello. I guess one question
I
I
will
would.
be seeing you, Kyle, in March. Colin and Kate are doing a day-long medical legal thing. So
Oh, awesome. Good.
um, yeah. So good stuff. And go Bucks. And sorry about the playoffs, but anyway.
Uh, I'm a
Okay.
transplant here from Oregon, so I'm not like diehard Bucks, but I'm getting on
Well,
board.
then sorry about Indiana.
I guess one question I would have is this appendectomy, this history of appendectomy, is this like very like recent, or was this remote?
So he's 5 years old, and let's say that it was I mean, it wasn't very, very recent. No, no, it's not like a
Oh,
fresh
okay.
surgical scar or anything. So let's just say,
Understood. Okay.
for sake of discussion, it was 6 months ago.
Gotcha. Okay. I mean, I guess one thing that's on my mind is just history of surgery and and kind of a sudden vomiting would be a bowel obstruction. I know maybe in a kiddo potentially less likely, but they have that history of surgery, so it's a
I think that's a fantastic thought. Kyle, let me ask you this because, we're all like very reluctant to, and I'm not saying it should have been done, but to image kids, to, do labs, like, um, what do you think about the diagnosis, just based on what you said, of gastroenteritis in a child who is vomiting without diarrhea?
yeah. I mean, in my limited experience thus far, I think it's kind of difficult to say gastroenteritis without diarrhea. I guess that this would be more, I guess, a presentation of gastritis. Yeah.
Perfect. Perfect. Love it. And we're going to come back into what you're saying more in just a second. Anybody else have any thoughts on things? And I can point a few things out also. So I'll just ask you guys to
I was
think.
just gonna
Oh,
jump in. Hi, I'm Carlin. I'm an attending, but early career, but just kind of some interested in med mal, so that's why I signed up for it.
nice.
But
Carlin, where are you practicing?
I'm with Mid Ohio Emergency Services here in Columbus as well.
Oh, nice. Nice. Good. Nice to
One thing I'll
meet
point
you
out is
again.
nursing notes. I always read through those because those can be kind of critical viewpoints. And I don't like that this kiddo failed his PO challenge, even with the grandmother saying, hey, he drank it too quickly. That's not satisfactory for me. So that might, with kind of that failed PO challenge, might cause me to do a little bit more of a workup.
So, Carlin, I love what you say because it's like caution, caution on when patients tell us their diagnosis. And look, the grandmother came in and said, he's got food poisoning. And then says, well, he drank his water too quickly. I remember this patient I had with chest pain. I'm like, have you had any sweating? It's like, yeah, but it was hot out in the room. It's like, any shortness of breath? Yeah, but I'm really out of shape. It's like, listen, dude, you be the patient, I'll be the doctor. I get it. You don't want to be sick. I don't want you to be sick. Just saying, answer the questions, I'll make the diagnosis, right? And so I love that you say that because that's one of the biggest also medical legal risks in any chart, not just emergency medicine, but when our evaluation does not comport with the nursing evaluation, and in all fairness, the patient, they tell their story to the security person, and then to the triage nurse, and then to the tech, and then to the nurse in the back, and then finally when we get in there, they're like, well, it's on the chart. I told it to the system, right? And so I just think it's really, really something we need to be cautious about when we think about the fact that this patient had a little bit of a different documentation from the nurse, and it wasn't really clear whether the doctor knew that the patient threw up. Um, Anybody have any thoughts on the GU exam being deferred? So there's a study, and I just actually talked about this with Eileen Claudius on MRAP just last week when I had the medical legal thing on the first Monday of the month with Eileen. And we talked about a study by Gauthier. I really need to figure out how to pronounce that person's name, where they looked at medical legal cases of missed testicular torsion. They found that 31% of those cases presented with abdominal pain alone. 31, it's about a third of the time torsion, at least in their series, presented with abdominal pain. So when I think about a GU exam, I think that that's part of the abdominal exam. In the same way, if you have elbow pain, you examine the joint proximal, the joint distal, right? In the same way, if you have a patient with abdominal pain, especially a patient who might be scared of needles or whatever, right? The patient doesn't always give you the exact information you want. And in fact, we know that there's another discrepancy here, and Carlin, just that you pointed out the nursing notes and the importance of that. This isn't necessarily between the nursing and the physician, but it's actually within the physician notes. The history says no stomach ache, but the exam says that the patient does have mild diffuse discomfort of palpation. So I think that's interesting. And to me, it feels like if I'm breaking a tiebreaker, the physical exam should be the more objective information that we're getting from this patient. So, what's the way to break the tie? Maybe repeat the abdominal exam after that fluid challenge, like Carlin, you were saying, or maybe it's to go back and ask him. And sometimes you can ask questions in a positive way or a negative way in the sense of like, you know, this headache patient, I'm sure you've had bad headaches like this in the past, or is this the worst headache of your life? Not a question that I ask, but the acuity of onset, of course, is important to me and to all of us, right? So, in the same way, this patient, there's some concerning things. Another concerning thing to me would be the patient's vital signs, the heart rate at 135. And I get it. If you recheck it, it's 120 or 110, all good. If you recheck and it's 160, definitely concerned. But what you need to do is you need to recheck it and repeat that abdominal exam. So what I want to do, I don't know if you guys have access to your chat, but I wanted to do what hopefully be sort of a fun exercise here, is think about the differential of a patient, let's say just a child, who has lone vomiting. All right, so this patient had vomiting, no diarrhea, and he's 5 years old. The grandma thinks it's food poisoning. The physician thinks it's gastroenteritis. Hey, if you're putting $5 down, maybe one of those would be the case in your average patient, right? But our job is not to just sort of play the odds. And our job is to make a diagnosis to make sure that something more serious isn't going on. So, what is the differential of a patient with lone vomiting? And then maybe what questions could we ask to sort of address that? So, I don't know if you guys want to humor me a little bit. You can unmute if that's easier, or if you want to type stuff into the chat. And again, save space. I appreciate you being here. If you don't want to do any of that, I can just sort of go through things. So I'll give you like 20 seconds if anyone wants to do one of those. Okay, pyloric stenosis. Yep. And you think about, maybe a younger child, right, with that projectile vomiting, probably don't diagnose the 4-week-old with gastroenteritis when they come with vomiting. So I have foreign body. Yep, that's certainly a good one. And when you think to yourself, okay, I've got a 5-year-old playing in the family room while the grandma's fixing breakfast, and then they're, for example, short of breath if it's tracheal, or maybe even vomiting if it's something they swallow. Probably is not a PE. Probably is not something like that. Something starting very acutely, right? So maybe that onset of action could be important in that situation. I have this segment that I do on UC Max, and it's called If It's Not in the Differential, It Won't Be in the Diagnosis. So what I'm going to do is flash up to you here, which is actually a fairly, and I think this is like super interesting to me because I'm sort of a geek, right? But super interesting differential. Think about a patient with DKA, new onset diabetes, DKA. They could absolutely present with vomiting. Simple questions: polyuria, polydipsia, polyphagia, maybe weight loss, maybe a simple urine test. I'm not saying one should have been done here, but that would be something simple to do, or even a finger stick, obviously. Ingestion. The grandma is watching the kid. She's got some opiates, or maybe like a, diabetes medication that she has in her purse, and or clonidine, and the kid gets into the purse and takes that medication. You could certainly see lone vomiting. Maybe this patient has a brain mass, not something unheard of, but asking questions to the kid as to headache. Hey, I bet your head hurts you, or does your head hurt you, or whatever. Asking questions to the grandmother, specifically, has he had any confusion, or does he answer questions appropriately, or can he say what his birthday is, or maybe doing a neuro exam for unilateral numbness or weakness, those types of things. Non-accidental trauma wouldn't be the craziest thing in the world to the grandmother. How is it watching Jordan? She goes, well, I live alone. I'm but true story, she was a janitor in New York City. I live alone in New York City, and I come down here, and I don't know what my daughter is doing, but these kids aren't raised right these days. He, speaks out all the time, and he doesn't listen. And I mean, certainly a possibility, right? How about carbon monoxide toxicity? Again, a little bit unlikely in the summer I told you it was Georgia, it was actually South Carolina. But at any rate, carbon monoxide toxicity in any of our patients now here in Columbus, Ohio, or anywhere in Ohio. Well, boy, wouldn't we feel bad if we missed that diagnosis? The way we found out about it was a wellness check. So thinking about a patient who has carbon monoxide toxicity, you have vomiting. Do you also have a headache? Anybody else at home has the headache or vomiting? Did you recently replace your furnace? Do you have a carbon monoxide detector? Is it worse in the mornings? I mean, all the questions that we'd ask, right? Some sort of electrolyte abnormality, I get it. Why would he have that? I'm not saying labs should have been done in any way, shape, or form, but maybe asking about any potential for that. Strep throat, um, that whole weird abdominal pain thing you can get when you have a strep throat or any sort of renal disease. Again, pretty unlikely with that situation. But all these things I think are interesting possibilities as to what's going on. Oh, okay. Carlin, you also said toxic metabolic obstruction, GERD, gastroenteritis, UTI, right? Or testicular torsion. That'd be another thing. I didn't even put that on my list, but that's a great thing to have on here. You can imagine someone who has testicular torsion might have vomiting, and when he's with his grandmother and maybe with a female nurse, right, maybe be reluctant to admit that that's where he had where his symptoms are. He has discomfort in that location, or maybe it's just presenting as that abdominal pain, like that Gauthier study. Okay, so we don't. I'm going to ask you to do one more thing. We don't actually have the actual diagnosis on this list, but I will tell you there was something that was present on this documentation that, if recognized, would have potentially, probably actually, saved this patient's life. All right. Anybody want to put in the chat or unmute as to what you think? And I'll give you just a second to do that there, but I will sort of come back to Kyle. What he had said in the beginning is this potential for small bowel obstruction. So I'm going to tell you what happens is this patient is sent home at 1:30. I remember they got there at 11:10. So it was there for about 2 hours and 20 minutes, if I'm doing my math right. And he sort of moped around the house a bit, went to bed early, didn't really eat or drink much during the day. Mother came home just before midnight after her busy day as a public defender with this case that she was trying, and said to her grandmother, or her mother, actually, the patient's grandmother, "How is Jordan doing?" And she sort of gave the story. I put him to bed early. He wasn't that well. And so she went into the bedroom and saw Jordan was what she thought sleeping. There's some green emesis on the pillow. They couldn't arouse him, called 911. When they got there, he had a weak, thready pulse. They tried to place IVs, weren't able to, did an IO line. Mother and grandmother were allowed to ride along. Jordan, unfortunately, in a very sad way, arrested on the way to the hospital. And unfortunately, despite a prolonged attempt at resuscitation in the squad car as well as at the hospital, he was unable to be resuscitated. It's all a totally true story. And unfortunately, what happened next day when they did a autopsy is that they found that Jordan did have, in fact, as Kyle was saying, a small bowel obstruction and a perforation. And what was that potential game-changing finding? And this is interesting here on the physical exam, and I'm not saying I would have caught this, but there was a well-healed midline scar. And this was more indicative, and they went back in the records and looked and found out that this was the case, that the reason they had a midline scar as opposed to some laparoscopy or right lower quadrant scar is that it wasn't just an appendectomy he had for appendicitis, it was an appendectomy for ruptured appendicitis, which was approximately 6 months or 3 to 6 months before this visit here. So interesting as far as this differential. And Carlin, thank you. I'm going to put testicular torsion on this for the next time I do this. But small bowel obstruction is what he had. How could we have made Jordan safer? Well, what if we had repeated that abdominal exam? What if we had repeated the vital signs? I mean, look, he arrested like literally less than 12 hours after he was discharged from the emergency department. Would his repeated abdominal exam have been worse? Almost for sure that would have been the case. And a lot of other things that we talked about also. Okay. I'm going to give you another case, and for this one, anyone is certainly welcome to chime in, but I want to make sure that we get to a couple of things that I have planned for the end here as far as some of the approaches, this revisit, record, recruit approach that I want to talk to you guys about. And I also promise that we will end exactly at 11 o'clock. So I, again, do appreciate the time you've given me. But anyways, that's a true story, very sad story. This is also a very sad story and a true story too. It's the story of Peggy, and Peggy is a 15-year-old girl. And she's a 15-year-old girl who had a broken home and lives with her grandmother. So she actually lives with her grandmother. Her mother lives in a different state, Arizona, and she is, estranged from her father and the siblings. Anyway, she's also had some mental health-ish type of problems, and she's had some cutting episodes on her wrist and on her leg. But this is an older case, but it could be exactly the same as today because nothing was really done besides just that bedside history and physical alone. But this was actually, interestingly, on the day of 9/11. And again, anybody that wants to unmute and jump in or put stuff in the chat, I'm happy to have you do that. So this is her exact chart. And Carlin, you talked about the importance of the nursing note. We're going to talk about how that sort of played out with this case. But Peggy developed some chest discomfort, or I'm sorry, some head and neck pain. You can see she's holding her neck there during the day. And she then, um, her grandmother, obviously called the squad and she got sent to the emergency department. So here's the documentation from the physician. I'm just going to bring out these purple points in here because I want to make sure, again, we have time for the other stuff here. Some nausea and vomiting of thin liquids. And the history present notes by the PA, as confirmed also by the physician, patient denies it is the worst headache ever. The review of systems was like, I don't know, written by a lawyer, probably, as well as this whole past medical history type of disclaimer type of thing. You can see in sort of a weird way, and I can oftentimes minimize the patient's elevated blood pressure, but in a 15-year-old with a pressure of 174/94, in the same way with Jordan on our last case, hey, you know what? Just break the tie. Just check it again. 110/70, which is most of my 15-year-olds, great. 200/120, probably something we need to worry about. Okay. On her physical exam, this is sort of interesting. She had head and neck pain. Neck is supple, no tenderness, no lymphadenopathy. I don't know if you can see my pointer, but that's down here in the middle of physical exam. And then an ED course, ibuprofen, soft collar neck. And then she's discharged to follow up in 2 to 3 days if she's not better. So the first thing I wanted to just sort of talk about is, again, getting back to what Carlin had talked about earlier, the nurse documented some nausea and vomiting of thin liquids, and then the physician, in sentence number 2, starts off by saying no nausea, vomiting. Now, I'm not going to have you vote because we're doctors and we're awesome, right? And we're always right. However, if you were a fly on the wall and the nurse says nausea, vomiting, thin liquids, and the physician says no nausea, vomiting, who would you believe? To me, I'm going with the nurse in this situation. And the reason I am is very simply, and this is a big take-home point from our discussion this morning, this is the more specific documentation. And the more specific documentation always wins. So if you say, for example, with your chest pain patient who has a history of an MI and is 50 years old and you're sending them home, I'm totally good with that. If you think it's musculoskeletal chest wall pain, I'm totally good with that. But here's what I'd prefer on your exam. The patient has point tenderness left lower sternal border, which causes the patient to yell out, withdraw from pain, exhibit facial wincing, and confirm that that reproduces their symptoms. That's very specific documentation. No one's going to say later, oh, that was part of their routine macro and that was a lie. I had a case recently where the documentation was amazing and I accepted the case for the defense. And then what came out later is the attorney went back and subpoenaed the macros or smart phrases, however you want to say it. And all of them were exactly the same as they put on every patient. And it wasn't actually what we thought accurate. And so then I unfortunately had to come back and tell the defense that I wasn't able to, in all conscience, take that case. At any rate, really think about this. And look, I get it with an ankle sprain, corneal abrasion, whatever. But when there's some diagnostic uncertainty, as we're going to talk about soon, you want to just be very specific about some of these types of things. Okay. All right. So let's go through things a little bit more here. The physician documented patient denies it's the worst headache ever. Well, I'm going to tell you how things can sometimes play out legally because there was a bad outcome, and this did go to trial, and they had the physician up on the stand. Actually, they had the plaintiff expert witness up on the stand. So the plaintiff's expert, they asked them, is it true that when a patient has severe pain, they're not always able to describe it? How did the grandmother describe the patient's pain later, that she was screaming and sobbing in pain? And when you look at things objectively, well, think about this. She had such bad pain at home that she needed to go to see the doctor. Her grandmother tried to get her into the car but was unable. They had to call 911. They transported her to the ER, and something I didn't even tell you, but again, there's witnesses, there's staff, and there's the grandmother and family and all these other people that are there. They remember when there's a bad bounce back that happens soon after a patient's visit. But at any rate, they weren't even able to transfer her from the ER cart, from the EMS cart over to the um, ED cart. So they weren't even able to do it because her pain was so severe. And I think to myself, how is not how is that not the worst headache ever? Like when did she have at the age of 15 a headache that was worse than this headache? So just because you say it doesn't mean it's going to save you later, especially if it's not true, can absolutely make things worse. Okay, there's some other interesting parts about this that we can talk about later, but I'm just going to go through things real briefly. Um, this is the actual the way that played out when a patient presents in severe pain. And if you go to the end, is it fair to say that the grandmother's version describes Penny as having severe pain at one point, screaming? Answer, yes. Sobbing. That's not noted in the physician's report, is it? That's correct. So, just think about that, obviously, when you put that documentation in. Okay. So when you think about a elevated blood pressure, maybe that's not the cause of the patient's symptoms. And I'm not a big blood pressure headache guy. I'm like a headache causing the blood pressure to be elevated guy, which is probably what all of us are, right? However, when you think about the fact that the patient does have elevated blood pressure, maybe that's in response to something that's going on. And as we all know, if the patient is having a stroke, until it's over 220 over 120, we should not lower the blood pressure because we don't want to get some type of watershed infarct. Okay. At any rate, what happens with Peggy? She's discharged home. She follows with the primary care. And unfortunately, and I'm so sorry to have all these really bad, tragic cases here today, she is usually up early for school, but one day she's not up. A few weeks later, her grandmother goes to check her, finds her unresponsive. They call the paramedics, and there's no attempt at resuscitation. She's pronounced dead. She also has an autopsy the next day. Her autopsy shows that she did have a subarachnoid hemorrhage, and that, interestingly, that's how she died, right? But the question was there a sentinel leak, a warning leak that happened when she was actually in the ED? They didn't see any evidence of hemosiderin staining. That's how they defended the case. And they said, well, if there wasn't any hemosiderin, then there's no way this could have been a sentinel bleed 2 weeks ago. And the fact is, of course, there could have, and that's incorrect data. But the plaintiff attorney, I'm sure very happy for the defense physician, NP, I think it was a PA, and they never rebutted that claim, and this actually ended up going for the defense, as the previous case probably would have also, but that previous one didn't actually go to trial. Okay, so I want to show you just one other case here, and then we're going to sort of wrap things up in the next 10 minutes. This is also totally true documentation. A 42-year-old woman, think about it, chronic abdominal pain, end-stage renal disease, and a frequent flyer. Love it, right? That's like the first patient you're going to see when you go back to your next ED shift. And this was her actual documentation. And I will say to this emergency physician, and you guys can see it, there's nothing overlying the documentation, right? We're good on that? Okay. Anyway, so good job on the quantity of documentation here, but not as great of a job on what I think is the most important thing here, which is actually that history of present illness, right? And that's, again, where I find most charts lacking when they go to medical legal. We know that she had abdominal pain, and we know that it started in the morning at the end of the first sentence. It began this morning. We know literally, this is me being a jerk, I don't know, being a tough critic, right? We know literally nothing else about the abdominal pain. And it kills me when I have residents and students who just repeat back the chief complaint to me. The patient has chest pain and she has a past history of whatever, and here's her social and her family. I'm like, can you tell me a little bit more about the chest pain? Because that's what I really need to know. How do I make the decision between ACS-PE dissection? In that same way, with this time, great quantity, good job, but not real good on the quality. She's obviously a vasculopath. vasculopath. She wants something for pain and nausea. She's asking over and over, i.e., physician annoyed and, doesn't need to be bothered. Obviously, she has vascular history with an ischemic limb requiring stent placement, and that's sort of recent to this visit. Can't quantify some vomit, some spit noted bedside, i.e., she's making herself throw up like how she's sticking her finger down her throat. And it says here, very poor historian. And I will tell you this, patients aren't poor historians. They might not be able to give a good history, but we are the historians. We're the documentarians. The ancient Egyptians are terrible historians. They can't give us any history because they're all dead and they've been dead for 4,000 years. In the same way, preverbal child, dementia, intoxicated, head injury, brain tumor, whatever it might happen to be, the patients aren't the historians. We're the historian. We're the documentarian. We're the investigative reporter, and it's our responsibility. That's why you get paid the big bucks, or maybe eventually, right? That's our responsibility. That's what we want from our family member, right? To gather appropriate data so then we can make that appropriate decision. Back to the Weinstock rule of malpractice, poor data gathering, poor medical decision making. Okay, so what happened with this patient? She's sent home. She comes back. We get a CAT scan and other labs at that point. She doesn't have mesenteric ischemia, but mesenteric necrosis from a big clot in the SMA. She's taken to the OR. She's opened, she's closed, and she's dead in 6 hours. These are tough. Frequent flyer, end-stage renal disease, chronic abdominal pain. However, without appropriate data gathering, we really don't even have a chance to make that diagnosis. Our medical decision-making is our closing argument. As we talked about earlier, that is our opportunity to answer the question, why? Why did I think it was reasonable to send this patient home? Why did I think this patient needed to be admitted? The medical decision-making is not a time to just repeat your HPI. The coders can look up in the HPI. They can look in your exam. If you order troponin, that's part of your medical decision-making in the sense of complexity. They know that you're thinking about ACS, whatever, right? The medical decision-making, there's no place for chart redundancy here. If you got tons of extra time on your ED shift, which I don't, well, do whatever you want. But I'm just saying this is our opportunity to answer why. And I give you an example of that. It's the 28-year-old woman on oral contraceptives who comes in with hemoptysis. Of course, we're worried about a PE. However, why did I not get a dimer or a CTA? This patient presented with 3 days of cough productive green sputum with some blood streaked elements with particularly vigorous episodes of coughing. Her 3 siblings are in the room and they all have URI symptoms. She has unilateral pain or swelling of the extremities, tachycardia, tachypnea, hypoxemia, like all those things. And I get it. Most of our PEs probably don't have those things. And I'm not saying that you should feel comfortable sending that patient home, but extending that MDM and speaking with the patient, she understands some diagnostic uncertainty. I feel it's exceedingly unlikely it's a PE. She understands. She'll return if her symptoms progress or worsen. We use shared decision making. She is going to go home and again come back if things get worse or change. Again, you might not agree with that medical decision making, but it's a reasonable medical decision making. Jeff Klein, who invented the PERC rule, told me that he's never seen a case of PE where PE was considered. It's always like, oh my God, I can't believe that turned out to be a PE. So anyways, that's just an example of how you could use medical decision making to explain the answer to this very important question of why. And a little trick on your discharge instructions, put that in your MDM. I spoke with the patient, the family, they're agreeable, they're comfortable, they understand the diagnostic uncertainty, they'll return if their symptom worse, change, progress, don't resolve, etc. But in the same way, put this in your discharge instructions. Simple phrase, as we discussed, comma, return if these things happen. And that's just another way to confirm that that conversation actually occurred. Okay. This diagnostic uncertainty, super important. What are the patients, who are the patients that we might miss? How do we spot the well-appearing patient who might soon be dead? I think of 2 things. Patients who have unexplained abnormal vital signs, such as unexplained tachycardia, as well as patients who have some diagnostic uncertainty about a potentially life-ending complaint. Abdominal pain, headache and fever, chest pain. We see tons of those patients, but just explain why you don't think those top 2 or 3 or 4 diagnoses are occurring. Put that in your MDM. And almost all the time that will be reasonable. You can hard stop what I call hard stopping your MDM because if you can't even convince yourself, and I sometimes, I mean, honestly, like last week, I'm like doing the same, like, mm, I don't know if I agree with that, put down the voice activated. And if you can't even convince yourself, there's no way you can convince a department chair, a family, a jury, right? Revisit, go back and see that patient again. That would have helped both Jordan and Peggy, potentially Peggy. Record, that's your MDM, and recruit. Recruit family members to say, hey, look, if you see these things happen, I want to make sure that you get that patient back in. So let me just give a quick summary. I'm gonna leave you guys like 60 seconds for questions. I will end at 11, but I'm happy to stick around all day if you guys have anything you want to ask me about. But just for the sake of Ohio ASAP and the recording, we'll end exactly at 11. So correlating the chief complaint with the question being asked, the patient's asking a question, but the presentation is asking a different question. Patient says it is an MI, is it a heart attack? The presentation is, could this be ACSPE dissection, pericardial tamponade, tension pneumothorax, Boerhaave, or whatever imminently life-threatening chest pain thing might be going on. It kills me, guys. It kills me that a good history is free, poor history expensive. Broken record alert. I told you you'd have a lot of that. The HPI has to be the HPI. You can put everything else in there that you want. Past history, sometimes it's super, super important. But the history, present illness, as we talked about this summer with the Ohio ASAP Resident Assembly, the history present illness has to be at least have included in it the history of the present illness. And that's that old car's mnemonic, onset, location, duration, exacerbated relievers, all those things, right? The physical exam needs to be documented objectively. I didn't show you the physical exam for that end-stage renal disease patient, but when they said on there is, the patient is whining about wanting more pain medicine, and they made sort of a disparaging comment in the physical exam. And the reason she wasn't answering questions appropriately, that she refused to answer questions, is because her entire bowel was dead. And she had that sort of labile indifference, that metabolic encephalopathy from a necrotic process. Using the MDM as a hard stop, we talked about a second ago. And then the biggest thing I want to leave you guys with, because again, that balance we talked about is so important. I don't want you to practice defensive medicine, but to evaluate and document in a way that is defensible. So thank you so much again for giving me the time, and I'm happy to stick around as long as folks want to answer any questions.
Thank you so much, Dr. Weinstock. I'll go ahead and stop record right now.
Perfect. Thank you again for having me.